Good morning, everyone. Happy Friday. It's a lovely day here in Colorado. For those who are not in Colorado, excited to have you all joining us. I'm Sarah Lampy. I'm the president and CEO of Prime Health. We're excited to have you all come this Friday morning and hear a little bit more about innovations in food as medicine, specifically focusing on food security and really looking at and understanding the pivot from food security to nutrition security. We have three excellent panelists and an amazing moderator joining us today who are going to be kind of lending their expertise on this topic and giving us a lot of food for thought as we move into this Friday. So I'm going to kick it over to Inka to get the introduction started. If you do have any questions you might have throughout the session today, please put them in the chat. We will kind of follow along. If there are questions we can answer during, we will. Otherwise, we will save them for the end. And if they're, just keep yourselves on mute so that we can listen to these experts speak. So take it to you, Inka. Hold on, we gotta make sure. Yeah, now you should be able to do it.
Great, there we are. Good morning, everyone. I'm Inka Deku. I'm the Nutrition Integration Specialist at the Colorado Department of Public Health and Environment. And I am just really excited to be able to moderate this conversation and really talking about and understanding the opportunities and challenges around innovations as it relates to food as medicine and food access and food security. And so we have three panelists joining us today, each representing different organizations. The way that we're going to run today's show is we're going to do, the first question is going to just be a general overview of each panelist organization, their role, and why they got engaged in food as medicine. They'll have a few slides to share with you all, and then we're going to get into a few questions to spark conversation, ideas from you all. We really want this to be interactive, so please feel free to chat comments, questions in the chat, and we will go from there. So I first want to introduce Ana Torres Leon from Children's Hospital Colorado. She is a registered dietitian in the Prevention, Education, and Outreach Coordinator at the Children's Hospital Colorado. And she is renowned in her work in translating evidence-based nutrition education into practice through innovative community programs and is a strong advocate for food as medicine model. Sarah, do you want to share your screen? There we go. Perfect.
Okay. Thank you for having me. I am a registered dietitian at Children's Hospital Colorado. I want to talk a little bit about our food as medicine model within the hospital system, within Children's. I do work a lot of the bulk of the work that I do. I work for the Healthy Roots Food Clinic, which we'll talk about. It's in my slide. So you can go ahead and go to the next slide.
Sorry, I'm having some technical difficulties with my share. It's saying it's paused. Give me one moment.
Sure, no problem.
There it is. All right, that should be good now.
Perfect. So we have some history with the food as medicine model and kind of where it all got started with food security within Children's Hospital. In 2017, we started the Food Security Council to identify the needs in the community and the patients that we're serving, and what does that look like when it comes to food security. We have a garden. It's a Healthy Roots garden. It's located at the Anschutz campus. Previously, there was a different goal for the garden, and we've shifted to now it's part of the Healthy Roots brand. So in the summertime, in the growing season, We utilize the garden for education for families and patients and their families. And then we also grow produce, organic vegetables and herbs. And that food goes to our food clinic. Speaking of the food clinic, it opened in 2019. It's located within Resource Connect at the Health Pavilion in Aurora. I'll talk a little bit about that in the next slides. As we all know, COVID happened. A lot changed for many organizations, especially nonprofits. So we did have to shift to emergency response, emergency distribution. So it was pounds and pounds and pounds of food giving out to the community. After COVID, we went back to our food as medicine model, and that's been the sole focus of the work that we're currently doing. So you can go to the next slide. Thank you. And so the Healthy Roots brand, we really focus on linking nutrition into health. We really want to keep kids in schools and outside of the hospital. So utilizing our garden, our food clinic, and our community outreach with the schools, with the public schools. We have partnerships with public schools. We want to make sure that it is coordinated messaging, that education that the families are receiving in the garden is the same education that they're receiving out in the community. As we know, nutrition is, there could be a lot of misinformation out there. And so we want to make sure that all that is all the same messaging throughout our system. It is a personalized approach, and we really work closely together with the Healthy Roots brand, the garden, the clinic, and the community in our partnerships, which this is a lot of what the conversation is going to be today. Next slide, please. And then this last slide, I just wanted to give some background of what a Healthy Roots Food Clinic is. This is my main hub. This is where I spend most of my time. And so this is a clinical setting for families who screen positive for food insecurity. And this is done through primary care visits. We see families and the patients and their families for 2 years. Each referral is good for 6 visits per year. The household sizes in our clinic, we see an average of about 4 to 5 people in the household, but we see larger families as large as 8, 10, even larger sometimes. The distribution is based on the dietary guidelines for Americans, which we'll discuss in a little bit in this discussion. We advocate for choice methodology. We believe that everyone has the right to choose the foods that they like to take home. And so in every consultation, the families are receiving nutrition education, which is based on our curriculum that we've developed based on healthy eating, active living. And then they also go over a menu of food items that are based on the food groups. They are nutrient dense items, and each family, the patient and their family, they get to choose the food items that they like to take home that day. We do acquire foods. They're charitable foods. Some we purchase through grants, and then during the growing season, we receive produce from the garden that we grow. Thank you. And we'll talk a lot more about this in this hour that we have together, but thank you. That was a good intro. Thank you, Anna. Yes, we will. I'm sure that our audience has a lot of questions. I'm thinking about a lot of things in the work that I do in public health. The next, we're going to introduce Jared Charon. He's the Chief Operating Officer at Cylinder Health. It's the largest virtual digestive health platform. He was previously the Senior Vice President of Operations at FoodSmart, the largest telehealth food care provider focused on addressing nutrition insecurity, where he really led the company's expansion and secured $200 million Series D investment. And he was also previously a healthcare consultant at McKinsey & Company, focusing on analytics and digital care management. And so he's really going to share the perspective of corporate and digital innovation in this conversation as it relates to food as medicine. Go ahead, Jared.
Well, it rhymes close enough. Well, hey, great to chat with you all here today. Although I work currently as Chief Operating Officer at Cylinder Health, as Inka mentioned, a digestive health organization. I spent a lot of my time previously at FoodSmart here. So I'm going to talk a little bit more to that as it's more relevant to the organization. I'm still deeply involved in that organization. So So about 10 years ago, I was working at McKinsey with health plans on how to address the increasing trend for Medicaid and Medicare plans. And so much of it was due to chronic conditions that were affected by nutrition, as we all know here. But what was being meaningfully done about it was pretty minimal in my view. Gastric bypass surgery was this kind of silver bullet. Livongo was still up and coming from a digital health perspective. And we were putting a lot on our PCPs who candidly just didn't have the knowledge or background to be able to address this at scale here. So I joined this company, Zipongo at the time, which rebranded to FoodSmart, and decided it was time to roll up my sleeves, stop dropping off 200-page decks, and get to actually building here. So what FoodSmart is today, which has evolved quite a bit from when I joined in a good way, is really a telenutrition provider. So largest provider of registered dietitians in a telehealth setting. Over 1,000 dietitians today work for the company, and it is serving primarily Medicaid audiences who are really struggling with food insecurity. Now, this isn't just traditional M&T that the organization is providing here today. And we even, as we're working with our dietitians and training them, there is a lot of screening and work done up front to say, hey, this isn't your M&T done in a traditional hospital setting here. We're going to elevate you to be more of the front line and to be the stars that we know you are to really make this change here. So it is a combination of both the clinical and the social side of things. On the clinical side of things, it is really around addressing a lot of these folks who are coming in with chronic conditions that we've seen time and time again here, and making sure that we are not just addressing those conditions today, but actually teaching folks how to fish over the long term here. And then on the social side of things here, one of the very first thing the FoodSmart dietitians do is they screen for food nutrition insecurity using the USDA questionnaire. And we could debate whether that's the right questions or not, but it is right the standard set of questions today to be able to say, is someone struggling with this? But not just that, but what do we do about that? So if a dietitian notices or screens someone and they are screening for food insecurity, they will actually go ahead and get them signed up for SNAP in that appointment. The SNAP sign up process, if you all have been through it before, obviously, as you know, it varies by state, which makes it complex, but even within the state, it is not an easy thing to do. So our dietitians will actually, it is unbelievable how few people even know that this is available to them, but even then, how hard it is to access. So our dietitians will sign people up for this here, but then show them how do they use the SNAP dollars or money provided from their health plan, their provider, whoever it may be, to actually purchase food, and what food should they purchase here. So this is where FoodSmart's created this healthy food marketplace here that screens out all the advertisements and things of that nature to say, hey, right, let's make sure we're using those funds on food that is actually going to help you and make you feel better here. And not just that, but how do we address some of these other barriers that we're going to talk about a little bit later, I believe, around transportation and access to food as well here. You can go to the next slide. So from an actual product standpoint, it is the pairing of the clinician, and that is, we know that access to technology is not always available too. So you can do these appointments via phone, via video, whatever the member feels comfortable with, but then providing a product that allows them to continue to, outside of appointments, execute on some of these changes and actions here. So for instance, being able to take a grocery list that's developed with a dietitian and say, hey, let's, instead of forcing you to make something that you don't feel comfortable about, isn't culturally relevant, let's make this grocery plan with you, and then translate it over to a grocery or across the grocery ecosystem through partners like Instacart and others to be able to do live cost comparison here. It is unbelievable how much the cost difference can be. I mean, you all probably have shopped around different grocery stores and seen, but based on what's on sale each week, even how much money can be saved. So it takes the same grocery list, compares the prices, and allows people to maximize the use of their SNAP dollars today. And then provide those groceries for pickup, for delivery, based on the individual's benefits, things of that nature. So if we go to the next slide here, it really is this, what FoodSmart's providing is this population health program to generally Medicaid, Medicare audiences to be able to address these chronic conditions, but to also prevent people from ending up in those situations where they have established those conditions, and then providing food as medicine to select populations here. So that is really around individuals that have been determined to have diabetes, to have specific conditions, to have nutrition insecurity where they can't get access to specific food, to be able to deliver medically tailored meals or leverage other benefits or programs to make sure that they can see sustained success here. If you go to the next slide here, and in Colorado, right, what that reimbursement piece, and I think we're going to talk about that a little bit later, becomes key. So medical nutrition therapy, for instance, is something that is allowed with no prior authorization, and food as medicine is allowed for very specific high risk populations here. There's certainly more work, and I think we've all talked about how hopeful we are that that will expand to become more broad at some point in the future to make that enabled for more people that need it today. And really this all, if you go to the last slide here, this all depends on being able to show good outcomes here, right? If as a for-profit company, if you're not able to say, hey, what is the impact backed by clinical peer-reviewed journals and backed by claim savings, then it's really hard to continue to get funding and reimbursement for these programs here. So it needs to be something that people are bought in and say, hey, great, this addresses all of the conditions related to nutrition insecurity around obesity, diabetes, high cholesterol, high blood pressure, et cetera, and is able to impact the plan in a way that they can say, great, this establishes ROI for me. I feel like I can continue putting more money in this and having people sign up because I'm going to see it affect my bottom line. It's something I can continue promoting.
Great, thanks, Jared. A lot of things are coming to my mind around that systems level work. In my role at the health department, I really lead with a policy systems environmental lens approach. And so we're looking across the different strategies, how do we address that systems piece to really influence that environment? But it comes through policy too. So we need that policy work. 1115 waivers is a great example to support this work. And then how to an institution like a hospital setting that Anna talked about. And this leads us to Leah Pryor-Lease, because I think she'll really wrap this panelist group up together with the work that she's doing in her organization and her past experience. She's the Director of Community and External Relations for Colorado Access. She has over 20 years of experience in nonprofit, philanthropic, and public sectors, and she really specializes in reducing disparities related to social determinants of health. Food access, food insecurity is a determinant of health. Her previous roles include leadership positions at the office of Congressman Jason Crow, the Proteus Fund, the Vocal Fund, and the Gill Foundation, where she advanced policy change and social justice initiatives. Leah, I'd love to hear what you have to share with the group.
Thanks, and thanks for joining us. I'm Leah Pryor-Lease, Director of Community and External Relations at Colorado Access. Colorado Access is a local nonprofit health plan serving both Medicaid and CHIP members across the state. Our Medicaid region is here in the Denver metro area. We are currently serving 5 counties, Adams, Arapahoe, Douglas, Denver, and Elbert. Our new contract kicks in July, so we unfortunately are losing Elbert. They're going to go with the Eastern Plains folks, and we're going to really be focusing in on these 4 areas as well as our 45 counties where we have CHIP families. But we work really closely with our partners here in Denver Health to serve our community. We're physically the smallest, but serve the most number of members. And all of our work is really formed by these 3 guiding principles you see on the screen, which is around demonstrating health plan excellence, becoming member-centered and person-centered, and promoting social justice. And so a lot of the work that we do both upstream, midstream, and downstream around social determinants of health really matches up with this principle or goal or value of social justice. And so it frames all of the work that my team, my community engagement team, as well as our colleagues across the company, and really have been challenged to push a more whole person health goal. So integrating both the physical health and behavioral health, and now newly strategically adding social health to that integration. And so we can go to the next slide. And so you can get a sense of how we work, and I'll share more specific stories about this. But as we think about how we are integrating um, across both the lines of business and the community work that we lead, it really is dependent on relationships, working with community, and most importantly, giving folks the help that they need when and where and what is needed most. And so I know we wanted to start out with sort of how we got into this work. And really, I'd say for Colorado Access, like all good stories, it just started with us being in the right place at the right time. During the public health emergency with COVID, our teams were out a lot more than I think they ever had been in community, working closely with community partners and trying to find ways to connect our members and community members with services. And, we were trying to find community partners who really trusted and to be our sort of conduit to individuals. And through that work, we just, we would be out in a church offering COVID vaccines, and someone would call over to our folks and be like, oh, the church pantry's out of food. And so we were stocking church food pantries with, culturally significant foods that the parishioners wanted to eat. And we're actually buying refrigerators and filling those to make sure that we had them in food deserts and our partners could have access to food as folks were coming in with really much higher levels of food insecurity. And this allowed us to really think, as how do we want to strategically approach this? And so we had two primary ways of doing that as funding models. One is our internal community giving program, which our team oversees. And that's more for projects like the ones we're going to talk about today with Project Angel Heart and Food Bank the Rockies, to really provide more direct service to our members and communities. And we also were really lucky to found the Colorado Access Foundation a few years ago. And they're really focused on those upstream root cause systems level and policy advocacy work that make all of the other work possible. So we'll pause there, I think.
I know each of one of your stories just could lead into the next set of questions, and so to take a pause, so I appreciate that. But this really goes into our kind of a lot of our conversation around the terminology of food security and nutrition security. There has been a shift in these last several years, especially I think with the pandemic unfolding, that yes, we can provide food and food access, but is it the right food? Is it the food that families want? Anna talked about that in her introduction. Also, really knowing what's available and using technology to get access to that, to know the cost of things. Food has gotten really expensive. And then Leah, you really talked about sort of that systems work as an organization that's serving the Medicaid population, and that partnership of direct service, but also thinking upstream. So there's been a big shift from food security to nutrition security. And I'd love for each of you to talk about how did your organization sort of make that leap? And what does that look like? Anna, you touched upon it a little bit, but I'd like you to go a little bit further with that, especially when you talk about the nutrition for the nutrients that families need. So I'll start with Anna with this question.
Sure. So for a long time, we were looking at pounds for food that we're providing families. And this has been like a constant problem that I know a lot of organizations have, and it's a difficult problem to solve, is what how can we prove that pounds of food, how is that significant? Is that really affecting health outcomes in a positive way? What is the impact? And so, we were asking ourselves at Children's Hospital, how can we translate that, the pounds of food or the types of foods that we're providing families, how can we tie that to nutrition security? How can we tie that to the nutrients that the families are receiving? What does this food actually look like? What does this food mean? And so we created this formula, and it's a guideline based on the Dietary Guidelines for Americans, which if you guys are not familiar with it, what it is basically a guideline that states how much food and what types of foods and the amounts of foods people need every day in order to achieve proper nutrition intake. And so what we did is we created a formula that takes into various inputs and considerations. So what it is we're looking at the household size. So what is the average of families that we see, the household size for the families? For our case, it's about 4 to 5 people per household. It's 2 to 3 kids to about 2 adults per household. We also take into consideration the calorie patterns, and calorie patterns, what it is the amount of calories that a person needs every day in order to survive and be healthy and prevent chronic conditions. And so we're looking at that as well. We take an average of that. We're also looking at the food groups. And so the food groups, we're looking at fruits, vegetables, proteins, dairy, and grains. There's also not only whole grains, but there's space for refined grains. So that's also part of our formula. And so what this formula gives us, as after we input everything, all the foods that we're receiving from Charitable Foods, it gives us the exact amount that the family is going to be taking home that week. And so we provide for our specific clinic needs and our families and our capabilities. We provide enough groceries for the families for 5 days worth of food for everyone in the household. And so just to give you an example, if a family is ordering apples, this formula will tell us exactly how many apples to give this family in order to provide them with the nutrition that the apple is going to provide for them. And so a family of 5 is going to take home 10 apples for the 5 days. And so we go through our menu, we go each item by item, each menu item, and our formula tells us exactly the serving size for each food to meet those nutritional needs for the whole family. So it's a very it's more of a scientific approach that we thought this is where we need to go in order to really prove everything that we're doing, all these programs that we're providing our families, all this food that we're providing our families, the nutrition education. I touched a little bit of our curriculum, healthy eating, active living. Is all of this effort affecting health outcomes in a positive way? So now we're not just looking at pounds of food for food security. We're really looking at the nutritional value of the foods that we're providing families on a weekly basis. It's a very cool tool. It's a very interesting tool. We've been utilizing it for the past year. It's been forever evolving. And we're hopeful that it's really going to bring really good information, really good data to organizations. And hopefully it's the goal is to make it replicable for other organizations to use, not just for dietitians. We really want to make it user-friendly to work with health educators and promotoras and volunteers that are working in the food system and that can utilize this tool in a more valuable way.
Amazing. Just amazing to hear that. And it makes me think about Jared and his previous role with Food Smart. But I'm going to jump to Leah next, because I think it would be great for Jared to wrap this question up, because we're hearing from Anna, who's in a clinic within a hospital setting. So very community, individual approach, family approach. Leah, please share some examples of the work that Colorado Access has done at the community level. So like just larger population and some of the programs you're supporting with Colorado Access. And then we'll wrap up with Jared to really talk about back to that individual, but very large population level technology.
Yeah. And so when we talk about our evolution, I always think it's really important to talk about like what we learned and sort of where we maybe misstepped. And I think it wasn't a misstep necessarily, but we were really reactively responding to a crisis. during the public health emergency. Crisis that really, none of us, well, not none of us, but, most of us were not prepared for. And so we were just responding. When we would see fires, we would send someone out to try and put it out. And so a lot of that just started as, well, we've got X amount of dollars. We can give X amount of money to X amount of organizations. And that was fine. And that was great. And it was getting food to people who needed it. And I think the bigger value add for us was the relationships we were forming and what we were learning and the trust that we were building with those experts in the food space, which really helped us to identify more strategic areas and more focused areas for our food and eventually all of our social determinants of health work. And so being able to kind of learn together and, sort of as our food groups are really, really very kindly helping us along the way. We were able to, I think, build a level of trust that created an opportunity for us to co-design what our social determinant of health strategy looks like with those partners. And so in addition to having representatives from across the company, we brought in a set of external partners from community-based organizations who work in these different priority areas around social determinants of health to help us form and prioritize the work that we want to do moving forward, that really encompasses all of our services, not just food.
And just to pull a little bit more from you, Leah, but like some
Oh,
of
sure.
your work around Project Angel Heart,
Oh,
Food Bank
sure.
Rockies.
Yeah.
Like I think
those. Go ahead.
No, and just because I'm very familiar with those organizations,
Yeah.
I know they receive funding from you, and I think
Yeah.
that's such a key point in this conversation is that, co-designing a benefit, it's a benefit,
Mhm.
so like, and so I'd love for you to just share those two examples. I'm just most familiar with Project Angel Heart and Food Bank of the Rockies,
Yeah.
and what that benefit is providing from it, moving from food security to nutrition security.
Yeah. So with Project Angel Heart, we really started with a fairly small-ish pilot, targeting folks with congestive heart failure. And even from a really small sample size, we're able to see some good results, which tied really nicely into some work that we had started with Food Bank of the Rockies. And so with that, we had to really think, is the purpose to feed folks? Is the purpose to get to health outcomes? Is it both? And so that kind of community level thinking and our pop health team really helped inform some of helped to shape the frameworks there. But we were able to connect Food Bank of the Rockies and some of our local safety net clinics and some of the federally qualified health centers with direct services through them. So rather than, someone screens positive for food insecurity in a visit and the doctors are like, well, we've got this list, we were able to set up relationships where those providers could refer folks in real time while they're at the appointment to get the food for health delivery boxes for up to a year. And so that was one area that was really, again, a learning for us. It was something different, and has helped to inform a new project that's launching this month, which I can talk more about later. And then, we also were able to work with our data teams to scan where are our members, where are we seeing these new pockets of food insecurity, and what are the health conditions that we're seeing overlapping with those, and to be very focused and aligned with our broader healthcare goals to push the right kind of services into those places. So co-location was huge. And also working really closely with our foundation partners so they can fund longer term capital projects. They've really been the driving force for a lot of our multi-year support and some of our more capital style projects. And so, they're out looking at really cool ideas like nonprofit grocery stores or co-op stores in neighborhoods that have lost access to healthy food, as well as, you know, benefit navigation. And so it's been a really great partnership between the two entities, and we're just, you know, we're excited for the next stage.
Thank you, Leah. Thank you for taking those few extra minutes, because
Yeah.
I love the transition to sort of that built environment piece as it relates to food access.
Mhm.
So I feel like this webinar could be hours long. So Jared, please wrap up the question and how all this ties into sort of technology, larger population health, but also back down to the individual level as well.
Yeah, for sure. And you know, it's been great hearing what Anna and Lee have said about this, because it's a lot of these problems are I think they've hit on a lot of the key issues here, right? So when we were talking with a lot of the Medicaid plans, payers that we were exploring partnership with, one of the things that came up was, oh, our food insecurity rates don't seem to be too high. It feels like could be doing better, but doing an okay job. And this especially became the case in a lot of urban environments, because the reality was, yes, they had access to food, but it was not quality food, right? It was a lot of bodegas, corner stores, which, as we all know, have a lot more ultra processed foods versus fresh produce and the real food that people need to be getting, because a lot of the traditional grocery stores had abandoned a lot of these areas or neighborhoods where they felt like they couldn't make enough money. So a lot of times what ends up happening in these situations is people try to solve the problems from their own lens. So what do? I just get in a car and go to the grocery store because I'm fortunate enough to be able to do that. A lot of the folks that we're talking about here aren't able, they don't have a car there, right? And then so the solution will be, oh, they can get on the bus. Think about actually getting on multiple bus routes, carrying all of your groceries across, doing that while you're often trying to work multiple jobs, right? It might take you an hour, 2 hours to do something like that you don't have in the day. And that has been the answer and the solution for a lot of these folks. So what FoodSmart started doing was saying, okay, let's change the screening process to screen for not just food insecurity, but for nutrition insecurity, to identify, are people living in a food desert? Do they have access to an actual produce grocery store here? But also incorporating technology. And the technology was not there. Like the technology that Anna was talking about, for instance, right, with that they're implementing, that didn't exist even 5-10 years ago. And COVID, I hate saying COVID was a good thing, but it really enhanced that technology and brought it along in a way that enabled a lot of these organizations and functions to operate at scale now. So what that meant was for FoodSmart, changing the product and ecosystem so that people could get groceries delivered to them, so they could get medically tailored meals delivered to them. A lot of medically tailored meal providers now can deliver to every zip code in the country. That didn't exist before here, right? Instacart, same way, and some of these other food providers like Instacart here. But paying for those grocery deliveries still became a barrier, an option here. So Instacart, as in their health program, has come along too, for instance, say, hey, we're going to cover delivery for some of these folks. Or the health plans have chipped in and said, hey, you know what? As part of the partnership here, we're going to cover those delivery fees here. So there's been a number of ways to eliminate some of these barriers around transportation and distance that's really prohibited people from getting real food, because they've had this very clear transportation barrier. And then the other part here that Anna had on before here was around this education piece here, right? You need to be able to, people have to know in the first place that getting that food from the corner store isn't going to get them what they need to get the outcomes and the health, the outcomes and goals that they have in mind in order to live a more healthy life that is absent of a lot of these chronic conditions.
Thanks, Jared. Yeah, I think technology is a huge opportunity with our smaller organizations and what's to come. So, like I said, this is just the beginning of many, many conversations. I'm just looking at time here, and I want to make sure we leave a little bit of time at the end. I always have more questions than we always have a lot of time, but I'm going to combine a couple, and it's really around the challenges of initiation and sustainability of these programs. funding is always what comes to mind, is how is all of this work being funded? What's the reimbursement model? But then what do you all need to increase the scalability of your programs? Because what do we do to get more clinics like Anna's in more hospital settings? What does that partnership look like? So I will start with Anna, and a couple minutes each.
All right.
I know it's a big, not a lot of
I
time.
know, it's a big question. So Children's Hospital is a nonprofit organization. Our specific program is completely charitable foods. I mean, even down to my salary and my colleagues, we're all grant funded. And so that is part of our challenge too, is how can we advance our program? How can we continue to evolve our program to prove that our program is working in order to get more funding? So it's kind of like this loop that we're in. And so we have to get very creative with how we utilize our funds, how we provide these programs to families, when and where, and the accessibility to the families, because we also want to meet them where they are. It's really easy to say, oh, well, we're here at the hospital, why don't you come to the hospital? But for some families, that becomes very difficult. And so that's where we kind of got this idea of our community outreach and developing partnership with the public schools. At Children's Hospital, we're serving children where the children go most every day. They go to school. So why don't we bring the food to the schools? And so that's how that partnership developed. And we have a similar food clinic in Aurora Public Schools. We're trying to develop that with our North Campus. And so just these partnerships are really important. When funding is an issue, when funding becomes a barrier, working along with organizations in your community is where it becomes crucial. We can't all solve the same problem like just us. We can't solve world hunger by ourselves. It's really an effort with communities and organizations and partnerships. And so that has been really important to us, and it has brought us a lot of value. It has helped us evolve and grow, even with the limited funding that we have.
I'm gonna go to Jared next. What are some of the things that come to your mind around some of the challenges and scalability from your experience with FoodSmart and your current organization?
Yeah. I mean, a lot of it does come down to can the technology continue to advance with what needs to be provided here to allow for being able to, right, can the food ecosystem really catch up to speed? And we could talk a little bit about this later, but data interoperability between organizations and healthcare continues to lag here. So, if someone comes into a food pantry here, could they be able to know and tell that if someone is working there, say, hey, by the way, you are able to get free access to this benefit here because of your health plan or who you're insured through today here, right? That doesn't exist here today. Same thing on the provider side of things, getting better, but there's still a ton of work to do here. And then there's the reimbursement model side of things, right? We talked a little bit about this earlier, but where FoodSmart in its early days, for instance, a lot of it was based on grants and funding there, but that money is very cyclical there. So what would happen is we'd provide benefits to people and then it would disappear, right? Based on when the grants did, based on changes in government and things of that nature. So a lot of it was, how do we make sure there is a payment mechanism in place and in a way that it feels ethical too, right? Plenty of pharma companies came to FoodSmart and said, hey, by the way, have you thought about getting in with the GLP-1s now too? Have you thought about including ads for these people? We'll pay you when you do that. And FoodSmart said, no, that doesn't align with our mission here. So a lot of it then became working with the payers to say, hey, this is really complex. How can we figure out based on what is allowed in your state here so that you can get reimbursed, given you have a very limited admin budget that you have to spread in across a number of things. How can we work in a way that you will get reimbursed for this? But how can we also help you with legislation to continue to move things forward so you can get reimbursed appropriately?
Yeah, and I'll just, echo, obviously, money and funding are always going to be a challenge for social good work. Colorado Access, we strive to be good stewards of public dollars, and so any of the healthcare cost savings try to put right back into the community through these services that aren't yet reimbursed, but also building toward that ideal future state. And so the new Medicaid administration contract, which kicks in July, was one opportunity to start really thinking about how can we do things differently and where can we integrate some of this health related social need work beyond just what's required and for reasons beyond that it is required, knowing that it is just something that our members need and it'll ultimately get them to the healthiest state they want to be in. We have been, thinking about the 1115 waiver process and what that could hopefully look like at some point in the future. So supporting our partnerships and these services right now through our community giving program, which we started tracking the giving in about 2020. And between 2020 and 2024, we gave about $20 million out to community-based organizations. A lot of that was COVID related, public health unwind related. But then a big chunk of it was social determinant of health work. And about 2 million of that was food related work. And so in addition to the funding to try these models, to test out where some of the challenges might be, and also to help prepare smaller organizations who hadn't been necessarily engaging with large systems like Medicaid or doing billing or even tracking the data that you need to do billing. We've been able to offer technical support as we go to get them ready for, when these do become reimbursable services. The 1115 waiver we have coming right now is pretty limited, but I think it also gives us a chance to test out some things where we know we may run into challenges. And this also relates to the scalability. Is a lot of our traditional food security and nutrition support, it's a challenge to enroll folks who are unhoused for like a longer term intervention because they need a place to get these deliveries. They need refrigerators to store the medically tailored meals that come once a week. And knowing our Medicaid population, they don't always have a consistent address. They're not always accessible by phone and maybe can't get down to meet with their care manager as much as we would like to. So what we did is we really mapped out, we've got a great, project management team who helped us sit down and actually flesh out a process map to identify those points where we might lose folks, especially at these points of transition where maybe they're moving from the medically tailored meal version to the food box delivery version, and to think about how do we fill in some of those gaps, knowing that the SHE is coming, but it's not here yet. And so like, how do we use the people power that we have? And so we're also working with a handful of partners at some of the health authorities to see what is it like to embed some community health workers there to just be the point of contact for our internal care managers and navigators. And thank you, Sarah, for putting the SHE. I forget the alphabet soup isn't intuitive to everyone. But really like taking advantage of the resources that we have now to build the foundation for that future state.
Well, yeah, I think you just really tied it all together, of all these conversations that Anna was sharing at the clinical level, Jared sharing from technology, and then just the organization of a regional accountable entity, ARRAY, as we call them in Colorado, our managed care organizations, or ACOs in other states. But I really love, we have about 10 minutes for those in the audience. Feel free to come off video or raise your hand. We'd love to have a conversation. Is there a question in your mind that you want to ask the panelists? Is there even a comment or something from your organization that sparked some ideas that you want to share with the rest of the group? We're all here to learn.
Hi there, my name is Simone.
Hi, Simone.
Hi there. I actually just graduated from University of Denver with my master's in nonprofit leadership, but I just moved to Vermont last summer, And I'm in the midst of starting an intergenerational community garden. And your panel was suggested to me, and I've been learning so much from what everyone is saying today. And I definitely can feel some of the challenges that you're mentioning. I have some obstacles here because I'm living in a Vermont is a complicated place. There's a lot of independence, but also a lot of traditionalism. And while the food is delicious, it's not always the most healthy. Yet there's a very strong statewide interest in gardening.
Yeah.
So it's a complicated place, but I'm very interested to hear more about what all of you have to say, and hopefully use this to help my community.
Does anyone have? Anna, you want to talk a little bit about the garden at Children's Hospital and how that sort of, I find that to be also an example of an intergenerational garden.
Yeah.
I got to visit 6 months before the pandemic. I haven't been back since, and so I'd love to come back, but I think that comes to my mind.
So our garden is not a community garden. It is more of an educational garden that is led by our urban farmer. Actually, we just hired another urban farmer to help her out. And so we utilize this garden for educational purposes. It's really transforming it also into a therapeutic garden. We believe that with mental health and kiddos, it really improving mental health also improve health outcomes as far as keeping them out of the hospitals. And so our garden does serve that purpose as well. As you know, being outside with plants and the textures and the colors and the sounds, it really it can be very therapeutic for a lot of these kiddos. Also kiddos that are inpatient, they're also able to visit the garden for therapies as well. And so in this garden, it's an educational garden, but then we're also utilizing this garden to produce produce for our food clinic. And it has been, I wish you guys could see when our families and the patients, they light up when they know that the food that they're receiving that day is coming from next door, and that it's coming from an organic and well-loved garden. And you can just tell the difference in the textures and the colors and just the quality of the food. And as clinicians, as health educators, it's really, it feels really good to be able to provide quality food to families who may not have access to these quality foods otherwise. And so, but there are challenges, right, with the garden, especially at a hospital setting. There's a lot of policies and procedures and that we need to follow. And so there might be some flexibility if you have a community garden and outside of an organization versus a hospital setting, right? And so just some things to consider. Also, what is the exact population? Are you trying to do programming? Are you trying to make it more of like a production garden where you're producing a lot of produce? Is it more of a demo type of garden? Like with our herbs, we don't have the space to produce enough herbs to provide our families. So that section of the garden is educational. So they can know what herbs look like, what we can use them, how we can use them for cooking. So that kind of thing. So it can be a blend of educational slash, production. And so, but getting your ideas down and making sure that it's well organized and thought out and having an end goal in sight and the stepping stones to get there is going to be really crucial for the success of the garden.
And I can share a couple of examples, like leaning back into my time when I worked with schools. And actually examples from my own family is, when we'd work with some schools who were hoping, to build out these community gardens and eventually get some of the double up bucks farmers markets at the school sites on the weekends. And so, they weren't having great turnout. And so we had the kids decorate bags on Friday and brought them home with the flyers like, hey, come. But one thing that really worked well was working with the kids on what the foods are and how to make them delicious. And so doing that hands-on work with the kids, because then they'd come home and be excited about it. And it's like, I use myself as an example. Like, I don't like spaghetti squash. I've never liked it. I'm not going to like it. I know it's better for us and I just don't like it. But our kids were learning how to grow vegetables like spaghetti squash in their school garden, and had a cooking class where they made it, and they were excited to come home and share those recipes with us. And so, I think that is something that has helped influence the piece of our food strategy that is about, I hate using the word education. I want to think of it more as like experiential, because folks know what they like. They also know what is healthy. But it's integrating it into their, either their cultural experiences, their day-to-day, the time that they have to prepare things. I'm really lucky. We have 2 community cultural navigators on my team who have really helped to inform how to better message some of this and share this information out with communities, where it doesn't feel like charity. It feels like a benefit. Like, because you are a Colorado Access member, you get this. Isn't that great? And then finding the right partners to help us connect with those folks more consistently. And so, one thing I'm just really excited about is there's a bill here in Colorado, Healthy School Meals for All. One was just making sure every kid got food whenever they needed it in school for no cost. The second piece of that was connecting schools to local food systems. And so I think a lot about our partners up in Weld County, very rural, also very high levels of food insecurity. And so how do we connect those farmers and the folks who are producing and growing that food with the schools down the street? And that's something I'm really excited about. And I hope we get to see the rollout of at some point soon.
Sarah, can we have another hour to continue the conversation? It just like, this is a lot of my work at the health department, and I just love seeing it all here in a webinar. So I was just putting in links as people were talking, just to share with you all what's happening in Colorado. But one thing I want to touch on is just, we had talked about limited access. Like, if you don't have a home, if you're sort of between housing, we just passed, we meaning Colorado, a restaurant meal program, which requires the Department of Human Services to apply for a restaurant meal program through USDA for a limit. So for folks that are on SNAP who have limited access to make food at home, could purchase hot food. Right now, you can't buy hot food in a grocery store. Even a rotisserie chicken is not allowable on SNAP benefits. And so this would allow certain populations that can't make food because they do not have access to a kitchen, they don't have access to refrigeration, that they can purchase hot food. And then my mind goes to FoodSmart or some app like that, really linking the two of being able to order food on your phone and using your SNAP card. And so that's like a perfect example of how we take technology and food access for a population that just doesn't have access to hot food. So really excited. That was really led by Colorado Blueprint to End Hunger, really was the advocate organization with that work. And yeah, this was just a really great conversation. I wanna thank you all. Sarah, I'll let you wrap it up.
Well, thank you all. You're absolutely right. I should have just let you finish it off and write it off into the sunset. Y'all did a beautiful job. Thank you so much for joining us today. We do have a panel coming up later this afternoon that's all centered on looking at across population health and aspects of what we can do with digital health for behavior change. Our final panel is also on the 15th. That is all around sustaining and scaling these initiatives. We'll have across all of these have exceptional panelists, and I know everyone will learn a lot from them. So do join. The link to the next session is in the chat. And then at the end of all of this, after the 15th, we will have all these panels available on our website. It's amazing to me how much these are all additive to each other and how much they're all feeding on each other without even knowing it. So thank you for your expertise, your time, and we will see you all soon. Have a wonderful weekend.
Thanks so much.
Thank you all.
Bye.
Thanks so much.
Yeah.